online survey of recent mothers, which we're currently processing the results at the moment. I think we've had quite a reasonable number of responses now, but I haven't seen the totality of the results, so I don't quite know what it's saying. But I hope that'll be coming out before very long.
Thank you, Martin. And Jill, do you want to do an introduction? We just, because there's a few of us, we just thought we'd see who's in the room.
Yeah, sure. Hi, I'm Jill, Perinatal Team Manager.
Great. Okay, so I'm going to share my screen and we should probably get started, and I hope people will join. So, okay, let me just start from the beginning. So the idea of this week, just let me know if that's come through. Is it looking just one slide or two slides here?
Just one at the moment.
Okay, I've got a new fancy layout for some reason, so I've got two. Never mind. So yeah, just really to say this is just an awareness and just wanted to spread the word about maternal mental health. And I thought it would be useful to look at maternal mental health across the UK and also just some of the picture around the world as well and where we are. So I'm going to share some, oh, where's it gone? Sorry. IT issues. Anyone who's social media savvy, please do use the hashtags and kind of spread the word. The timetable link is there, although I would say don't use it right now if the links are all not correct there. So we'll hopefully be on working to sort those out. And that's our Twitter page as well, if you wanted to tweet as we go along. Right, so some of this you will have heard before, and some people perhaps this will be new and they've not heard things, but generally perinatal and maternal are kind of words that you might hear a lot around this period for a woman. And it's just perinatal is the Latin for around, and natal is the Latin for birth, hence obviously perinatal. And in this case, it refers to the perinatal year, it refers to pregnancy and the postnatal year afterwards. And when we talk about perinatal mental illness, it's obviously during that period as well. So it also includes illnesses that perhaps mental illness that existed before pregnancy, as well as those that develop for the first time or become increased or exacerbated in that perinatal period. And some examples of some of the kind of conditions we work with are antenatal depression, which up until not that long ago was unheard of. It was always considered postnatal depression, but actually we know you can get depression during pregnancy, and that's the antenatal depression we're referring to here. Anxiety, OCD disorders. The most extreme is obviously postpartum psychosis. Post-traumatic stress disorders. We know that birth trauma can lead to these things too. There's the severity of these is across the range really, to mild, moderate and severe, all with having different ways to treat. And do interrupt me if there's any questions. So I can't see the chat, so I'm hopeful, Jill, you might be able to do that for me. Just another information about really the physical and the mental health of the mother and the family environment during pregnancy is really, really important to mental health well-being for the family, as in just a holistic way, really. And the ability for a parent to bond and care for their baby, the style of parenting they may use, and the development of positive relationships will then go on to predict a number of physical, social, emotional and cognitive outcomes through to adulthood for that child. And I think there's been a study that's followed children, I think they're up to about 20 years now, where they followed them from the beginning, where the parent had a mental illness. And I haven't got the reference to that. I should get that, because I think it's really useful. And it's looked at the child's development over 20 years. So it's the only longitudinal study that they've got at the moment, and there are more being conducted to look at what happens. And they've identified that it does impact the child's development and through to adulthood. So the relationship between the mother and child is really important. We also know the mental health of fathers and other caregivers should also be considered and is also just as important. And we are hearing more about paternal and fathers' mental health, and we are looking at ways to be able to support them too, because they've been kind of not addressed for a long time. So there's more and more evidence coming, and more projects and more interventions that are available. And it is taking shape now, which is great. So paternal, maternal depression has shown to have a negative impact and the long-term consequences. So the risks around this period is factors such as poverty, migration, extreme stress, exposure to violence, abuse, like domestic, sexual, gender-based, emergency and conflict situations. And this is a little bit global as well. So natural disasters, conflicts, so war kind of countries, and areas where there isn't as much support or kind of structures in place, like primary care systems, they will all add to the level of risk that women will experience. And again, there's a few more risk factors in terms of postpartum depression. So if you've got a previous history of mental illness, we know that you've got a percentage increase of getting those a relapse, or the situation becomes worse during pregnancy and afterwards. If you've got a history of childhood abuse and neglect, this often raises, it kind of could be dormant for a while, and then you find in pregnancy it raises or triggers women, and their experience kind of comes to light, something perhaps they might not have talked about. And actually now they're having their own baby, their own child, a lot of this thing, these thoughts kind of come to front. Domestic violence, interpersonal conflict, we do have a lot more evidence about the impact of the couple, and if there is conflict in the relationship, and actually the damage and impact on the child from that as well. And it links in very closely with domestic abuse as well. If you don't have enough support, we know that it's really difficult to struggle and manage, and also if there's drug or alcohol use. And we also see risks for somebody who hadn't planned to get pregnant, or if they didn't want this pregnancy, but have to, or for whatever reason are having the baby, and the risk of postpartum depression for those women will be higher than anybody else. And then also migration status. And as we know, the UK is very transient in population as well. So people come and, it's really difficult to get started and settled in the country, getting used to the systems, knowing what's out there. If you haven't got leave to remain, or it's very unclear as to what your situation is, these things play on women's minds, families' minds, as to are they tomorrow going to have to go and be moved to another area or asked to leave. And these things will all increase the risks of somebody in pregnancy and afterwards. Just talking a little bit about the history, really. So if you've had a bipolar disorder, it's a 50% chance of relapse in pregnancy and postpartum as well. And it also, in terms of having a postpartum psychotic episode as well. And some of the talks earlier, we've talked about bereavement. So if you have a miscarriage or a stillbirth, you're also likely to it's also likely to lead to mental health problems in both parents as well. We often think about just the mother in this, but actually both parents suffer. The maternal mental health clinics that you may have heard in the news are one of the areas that will be able to support women who've had a neonatal loss, bereavement, miscarriage, and birth trauma. So once those kind of clinics are in place, those women will be able to access support. There's a huge gap for them at the moment. So at least that's been identified, and it's part of the long-term plan to have that in place. So by April next year, we will be offering we will have set up our maternal mental health clinics in order to address this population. Just also to say, routine antenatal and postnatal appointments are perfect opportunities for professionals to ask the questions about women's emotional well-being. And if the partner's in the room, I think that's also, every contact counts, and you have to be able to feel you can ask the question about a woman's mental health or well-being in order to get the support early on. And again, same with maternity and GP practices, often have contact with the family throughout those early periods. And again, as we were talking in the session before, maternity, if there was something on the wards perhaps at that time, when you've just given birth and had a traumatic birth, and just having someone to talk to, whether you talk to them or the timing's right, but just knowing that somebody's there could be quite useful as well. So I wanted to talk a little bit about why perinatal services have started, and some of you have also probably seen this slide before. And this is a really good infographic which was set up by the Maternal Mental Health Alliance in their Everyone's Business kind of report that they did, looking at the costs across the population in England, well, in the UK, and how much is borne by healthcare, public sectors and other wider society. And also suicide in maternal deaths is the second leading cause of maternal deaths, which is a huge number. And then the next slide just puts a little bit more into context about money as well. So we know that perinatal depression, anxiety, psychosis carry a long-term cost to society of 8.1 billion each year for each cohort year of births. So it's about 10,000 for every single birth in the country at the moment. And 3/4 of that cost relates to the adverse impact on the child and not the mother. And often we forget about what happens afterwards and its impact on the child. And then 20% of the cost, the total cost, so that's 1.7 billion, is paid or borne by the NHS social services as well, because we are those services then that will be intervening. And finally, the average cost to society of one case of perinatal depression is around 74,000. So 23,000 is to the mother, and 51,000, which is double, is to the impact on the child as well. So it really just highlights the big picture here, and the need for perinatal services in the UK. I can't see anyone, so I'm hoping everybody's okay. I'm waffling away here.
All good, Aki, we can see it.
Thank you. Just briefly touch on the NHS plan. So 85% of the country in 2015 did not, well, 85% of localities, I should say, did not have any specialist perinatal services that was recommended in the NICE guidelines. And so as part of the 5-year forward plan, there was the objective that this needed to be increased to support all areas by 2020 and to 2021. And actually that has probably been achieved. It's been massive work going on to increase provision. And we started with 30,000 women needing to kind of be accessed. I said that wrong, actually. At least additional 30,000 women were to receive evidence-based treatment closer to their home when they need it. So it's the targets to reach out to 30,000 women at least. And a lot of money was put into this. So 365 million was put into setting up our service. And luckily, we have some of that money. And hence we have a service that covers 5 boroughs, which is multidisciplinary. And we've been able to really expand. Following on from the 5-year forward, we have the long-term plan, which talks a little bit about some of the things we've already raised, which is about the maternal mental health clinics, an increase in accessing 66,000 women accessing support is the aim by 23-24 nationally. So there's just a little timeline. So in 2017 to 2019, there was a huge increase in workforce. Lots of training was put on because it's such a specialist area. And then by 2019, there was a service in 44 local NHS areas in England, in all of them. So 13,000 additional women were seen against the target of 9,000, and that goes up every year. So this year, across the country, the target is 66,000 women, which is around the top 10% of our birth rates. And the transformation also saw 4 new mother and baby units opened. So beds, total number of beds was 154 beds across the country. And I think Wales has been the most recent to open as well. And I think Scotland is probably still not so well resourced, but they do have two mother and baby units near the borders as well. Just wanted to talk a little bit about the global picture. The Global Alliance for Maternal Mental Health is something that was set up it was a coalition of lots of organisations that were committed to improving the mental health and well-being of women throughout the world, really. And because worldwide, maternal depression is the most common serious mental health complication of maternity. This and other mental health problems in pregnancy result in huge human and economic costs for this generation and the next. Yet in the UK, we are on track to getting services. There are so many other areas that still have nothing, and a lot of areas need that investment and research. So this alliance was set up to be able to kind of spread the word, get the message out there that this needs to be tackled globally. So a recent meta-analysis showed that 20% of mothers in developing countries experience clinical depression after childbirth, and it's such a large number, and it is a major public health challenge. So this figure is actually quite higher than the prevalence coming from mostly high-income countries, with suicide being the important cause of death amongst pregnant women and postpartum women, whereas psychosis is much less common but may also lead to suicide, and in some cases harm to the child. And the World Health Organization also did more research, which I'm coming on to, in terms of what it looks like across the world. And depression, we know, causes enormous suffering and disability and reduced responses to the child's needs. So it matters where you live, really. I couldn't find a picture, so I ended up using lottery balls, because it is a lottery as to where you might get the support. Not so much in our country anymore, but more across other countries, middle and low income countries. But research also suggests that it's not about what services are available, but it's also about what women will engage with, what mental health services they will engage with. And so we need to have a better understanding of the cultural perspectives in order to be able to, understand the variability of care and the levels of stigma related to mental health in the perinatal period. So the 2008 report by the World Health Organization reported that maternal mental health was studied in 90% of high-income countries, but data was only available for 10% of middle and lower income countries. So there's a huge difference in that information and research, and so this lack of data is concerning. as the evidence that is available suggests that common mental health problems such as perinatal anxiety and depression are actually more prevalent in women from lower middle income countries compared to those in higher income countries. And in 2015, Ativ, Lovell and Rahman reported the weighted mean prevalence of depression and anxiety during perinatal period in the lower income countries was found to be 15.6% during the antenatal period and 19.8% during the postnatal period, which is higher than those reported in higher income countries. So I just think it's really useful to understand what's going on around the world. There was another study which looked at postnatal depression, and obviously the figures are there. So 23% in India, 48%. I was quite shocked to see that number. In Nigeria, with Indonesia at 22.4%, Bangladesh at 33%, Pakistan at 25%. Ethiopia was even higher, 59.5%. But the numbers were lower in Brazil, China, and Mongolia and Uganda. So although there was variability, the question is how were these women recruited? So that's something to always kind of bear in mind, really, in terms of the disparity, because that also could reflect the cultural variations in the expression of mental illness. So how women express what's happening with them and how it's kind of identified as a mental illness or a cultural problem. So the cultural issues will probably have implications for screening and highlights the value of getting validation studies for how screening of mental health problems are kind of carried out in the different populations and the ethnic communities, because what we might use, say here, might not work for another country. Let's say that we've got to tailor these things for their needs.
So it's nearly 60% in Ethiopia.
Yeah.
Wow.
And that was a report. Hold on, where have I gone? That was a report in 2012, which I was just really quite shocked about as well. Nigeria and Ethiopia.
Yeah.
I mean, 2012 is 9 years ago. I wonder what the figures are. It was really difficult to find more recent data on this. And I think that's because countries are putting services and doing more research now. And actually, I don't know if it's been released or it's out there, or I wasn't looking in the right place. It was quite hard to find the information. We've not got many slides, so I'm aware that I'm talking a lot. So just talking about the cultural aspects of this. And so in the absence of specialist services like our own team, where we have multidisciplinary staff, community-based and psychosocial interventions have been shown to be quite effective in the lower middle income countries. And that's probably because they're probably more sensitive to the cultural aspects of that. Whereas we know coming into the mental health system in the UK has a whole load of other kind of stigma issues and assumptions, let's say, attached to them. Whereas I think if things are perhaps more community-based, a bit more in the norm, it's less stigmatizing. If we say to people that this is normal, this is for everybody, I wonder whether people would approach it and use it more if we are not considered. So one of the examples is being under a mental health trust. Would it be more suitable to be under an acute trust and providing this service? It's just some questions to think about in that. Would women feel more comfortable be able to access us if it wasn't a mental health trust, let's say? But it's also about making this that it's normal. This happens, and that these are what we can services that we can provide and help with as well. So just going back to kind of the international aspect of this, it's still very much neglected across many countries in their agenda for healthcare, and it is about kind of raising the voice as much as we can. So if you can sign up to the, not as an organisation, or why not, let's say, but as an individual, you can sign up for newsletters and pledge your support for the Global Mental Health Alliance as well. And they do have seminars and they do have conferences where they come together. If you wanted to hear of what's happening in, say, I think Gambia has recently kind of started a new service, and they were talking about that in one of the, and it's just such a contrast to hear how things are in a completely different country to how we have things here, and what we can learn from each other as well. So we need more evidence, we need some more research, and we need to be able to share this information across the globe. So I'm kind of finishing on my kind of last slide, and then I've got a video for people to just kind of finish with. So really, what should the priority be? And we've probably heard this saying so many times, that there's no health without mental health. And so it is really important for us to be able to get the right support to empower women to identify how to access help and their own kind of resources and personal capabilities. We want them to be able to enhance their resilience to life circumstances to help them nurture their children. And this is not, I'm not talking about the UK, this is globally too. And caring for mothers is a positive intervention for long-term social development. So when we're seeing women, or when we know friends or family, it's really, really key that we ask how they're really feeling, and encouraging them to really speak and seek help as well. But you know, to get that and to be able to signpost somebody, you need to know and understand what maternal mental health is, and what can happen, and how people experience it in different ways. So, any questions? Nope. I'm going to stop sharing in a minute and put a video on, but I've got about 4 slides of resources which I'm happy to share with people. These, if you hover over them, you'll be able to get directly and go to the links. So I'm very happy to share them. The Royal College has lots of leaflets, also available in quite a lot of languages. And translations, in order for very different communities to be able to access. There's support for partners, carers, there's social media platforms which you can access, and then guidelines that are used to kind of develop services. And that's my slideshow. So let me just come out of there. Where am I? And come back. And see how we're doing. Oh, Martin, you've got your hand up.
Yeah, well, I should ask you some questions. Thanks for that run through. That was very good. And would you be able to send me a copy of the slides? I'd be very grateful.
Yeah. Yeah.
But I mean, as you've pointed out, there's a lot of effort being put into increasing the availability of services and the access to services for women in this country. I mean, in terms of your experience in your area, our area, how far do you feel do you feel you've reached the bottom of the barrel, as it were, that the services available, that the people who need to be reached are being reached, or do you think there is still a way to go? And what are the priorities? I guess one element, that I was reminded by what you were talking about, the cultural differences and differences in different countries. I mean, we have cultural diversity here, and are the barriers to access on cultural grounds here too?
I think in terms of the access numbers, I think we've worked very hard to be able to try and reach them. I'm not sure anyone across London has been able to reach the targets, which were set to about 7% last year, instead of 10%, because services were starting and we were acknowledging that there were difficulties, and then obviously COVID kind of came in the way. But we were very close to getting at least to our 7% as well. I don't have the exact numbers, but I'm aware that it's
7% of what?
of the birth rates in the area. So
Yeah,
that's
right.
14,500 babies. That's the birth rate across our patch.
And I mean, is the target moving up beyond 7%?
Yes, 10%. The top 10% is the overall target that we all need to reach.
And I mean, how well based? I mean, what's the basis for that target, do you think?
I think that's what's just been set by NHS England as identifying as the top 10% of the country's population of the births will need mental health support, given the amount that the 1 in 5 women that have a mental illness during that period.
But presumably, in terms of the people that you're seeing, the referrals that you're getting, the more people you're getting referred, presumably a proportion of those you start to feel don't actually need as much help as the others, or?
Yeah, I mean, we can signpost. We signpost onto primary care services and IAPT. We may offer an assessment and identify that they would benefit from one of the primary care services, or we may, it's difficult to know, but we do have structures around in terms of being able to refer people onto so that they...
Does the proportion of people referred to you but felt more appropriate for other services, does that proportion getting bigger?
Yes, I think so. I think so, but I think that's also because more services are becoming available and more aware and taking, I suppose, providing a more appropriate service.
Yeah.
I don't know if it answers your question.
Well, I suppose it's hard to know, really. I suppose it's just well, I mean, you know, if the government wants to set a target, then you better work to the government's target.
Yeah. I think and I think, you know, as we come out of lockdown, I think things will probably start to, you know, increase, and demand we've already seen an increase in demand as things are kind of coming out of lockdown as well. Well, actually, I think our demand kind of didn't really drop so much. If anything, it's always kind of, I don't know how you feel, some of the team are here, whether they feel the referrals increased. I mean, I certainly think they did in peaks and troughs, but mostly it's been going up. Any thoughts, anybody? Silence. I think because you guys are on the ground and you have your referrals meetings, you've found it's been more and more referrals every week. So some weeks we might have, say, 8 referrals per patch, and then the next week it could be 14. And then across the team, let's say if you add all 5 boroughs in, we average around about 92 referrals a month.
And what about the issue of diversity and so on?
Yeah. We recently did we looked at our population and also the referrals and the kind of makeup of that. And we're doing really well in terms of our targets. We are probably under 10% out either way of reaching reflecting our communities that we work with. We've got a plan for the rest of the year to be able to increase the knowledge in the team and us, actually the trust in sharing our cultural aspects that we're all kind of looking into, and how this might impact childbirth and the child rearing practices of the women that we work with, the communities that we work with. So every month we have a 2-hour workshop where we look at 3 or 4 different cultures and share that with the team, and then that will also be available as a resource across the trust for other services to access. Right. Are there any questions? I was going to show a video. Are you happy for me to still put that on? It's just a way to kind of round up the session and end on. I can put that on 1 second. It's about 5 minutes. Some of you may have heard it before. If I can find it. I'm just going to stop because I remember you have to press something when you share for sound. There we are. Has that come through?
Yep.
Yeah.
Perfect family. There isn't a perfect mum.
Maternal mental health issues can happen to anyone.
Asking for that help early on is really key.
When I got pregnant, it was a very happy surprise. My husband and I have been together for several years, and it was the next step for us.
Normally she's quite a happy, jolly person. There were days where she couldn't do anything, just sleep, have headaches, sleep, have headaches.
I felt very out of control. I started struggling to breathe because I thought the baby isn't safe in my body feels physically unwell, there must be something wrong.
I just felt really indifferent to her. I just felt so sorry that I'd made this mistake and chosen to bring her into this world.
I didn't feel depressed or down at all. It was almost the opposite. It felt like somebody had just ramped me up a few gears. And what I found difficult was I couldn't calm myself down.
In wanting to protect them, got to the point of wanting to keep them safe from me and questioning whether I was safe. The thoughts would just keep coming back, getting harder and harder to shut up.
I was in a bit of a panic when my family were not going to be here to support me. I was like, I'm going to cope without them.
I just thought, actually, I don't want to live like this. I knew at that point that I needed to ask somebody for some help.
The first person I spoke to was my midwife.
I was crying, I was shaking, I was confused. And they said to me, don't worry, we will take care of you. And they did.
They referred me to all the right people.
Hi, my name's Sasha. I'd just like to come with me.
She wasn't judging me, and she made it feel really normal.
If you just take a seat.
I'm just finding this too hard, and I need some help.
The more you talk, the easier things get.
I've been trying to show everyone that I'm coping, but actually I don't think I am. We decided that actually the best thing for me was to have tablets,
which helped to minimise my physical symptoms so that I could access the deep breathing and the talking therapies much more effectively.
And I knew at that point I was going to be all right, but that it might just take a bit of time, really.
I came across a local charity who had a peer support group.
Seeing mums that were going through similar stuff than me made me feel that I wasn't just going crazy.
Having routine really helped.
A, getting exercise, B, getting away from everybody, and C, just getting some peace.
If you can give yourself some sleep, the world often looks brighter.
People like helping. I would accept any help that comes your way and just grab it.
Just playing with the baby or bathing the baby or feeding the baby and trying to enjoy that time.
It's just about enjoying what you're doing right now.
Just be the best parent that you possibly can be.
If it looks like someone's not coping, offer a helping hand in any way that you can.
Do not be ashamed of what you might be feeling, because you are not alone. It's a journey.
There is light, and you just cling on.
It will pass.
It will pass.
It will pass.
I'm just going to, still playing in the background, 1 second, take that off quickly. And that was just a really nice way to kind of pull things together, let's say. So I just wanted to end on that, really. Are there any questions or?
Is that on YouTube for anybody to
Yes.
Yeah.
If you type perinatal positivity, it's available, and they've got smaller ones, and they've also got it translated into different languages.
Yeah.
That was my question too, Martin. Thanks. If we can share it. It's a really good video to summarise and to show the journey, isn't it?
It'd be nice to put it on our trust website, actually, as part of something for this week.
Yeah, I was just thinking that was, you can use it with social media for people to watch, and then if people want a bit more advice, they can attend some of our workshops for the rest of the week, can't they?
Yeah, I think you can get it Italian, Spanish, Portuguese, Arabic, Urdu, and French.
Oh.
So it's really good. Yeah. So I think, I mean, I think it also reflects that that people are trying to be more culturally sensitive and have a wider reach in by translating things as well. So, and our leaflets, our team leaflets, we've translated into 6 languages as well, so which are also available on the Trust website. So great. Okay, if there's no questions.
Well,
Thank you
very much, Jackie.
Thanks, Jackie.
Thank you.
Thanks
So much.
Okay, good luck for the rest of the week.
The links have been amended all, by the way.
Oh, have they?
I've
Okay,
recirculated them.
Yeah, there's some really good ones coming later on in the week as well, in terms of infant brain development and psychotherapy and fathers as well. So if you can join, that would be great. Spread the word, because I'm aware we need to be able to have a wider audience, and there's a lot of my team here because they've been forced to come.
Definitely, we'll get it on.
It does help. The support does help. So I'm going to stop the recording and wish you all the best and have a good rest of the day. Thank you for coming.
Thanks very much.
Thank you.
Thanks.
Thanks.
Okay.